vitamins and minerals. Why do we have to have vitamins and minerals? To live. Yeah, absolutely. Can your cells work without proper nutrition? You know, you think about a person in end-stage cirrhosis. Are they nutritionally sort of malnourished? Yeah, you know why? Breakfast, lunch, and dinner. So they're deficit on everything. And does that ultimately lead to tissue issues and organ issues? Obviously. So yeah, so we need for cells to work, for tissues to work, we have to have proper nutrition. Intros and then trace elements. We're probably not going to do a lot of trace elements in here. Let's go to week 2. This is when we get into, and I'm going to make it really simple because it actually is. Next week, oh my God, and this is one of the funnest things, is this one right here. You guys, on your first test, you're going to have to know inotrope, dromotrope, and chronotrope. Okay, so that's going to be primarily. Who knows what those terms mean? What's an inotropic drug? A positive inotropic drug? Digoxin. Yes. Very good. And what does it mean? Like if you were a positive inotropic drug?
Is it for the contractility
Yes,
of the heart?
girl. Yes, bless you. Oh my goodness. You guys can pass these around. Who's first? I think it was over here. Yes, contractility, the strength in which the heart contracts to produce some good cardiac output. See? A person in heart failure who has very weak inotropic power this could lead to cardiogenic shock. Would you agree right here? And ultimately, mods if not treated. Now they may need, we'll give them digoxin squeeze, but then they might need that too. Electrical, pump to the left ventricle. But anyway, inotropic. What does dromotropic mean?
The conductivity.
Yeah, and what does that mean? Like if you're a positive dromotropic med. To increase conductivity. Now that is a little bit different from a chronotrope. What does chronotropic mean?
Heart rate.
Heart rate is specific. So you see the difference? The difference in a chronotrope and a dromotrope is remember, and it tells it right here, there's an HR. There's an HR right there, heart rate. So I want to ask y'all this. What do the positive chronotropes hit to make the heart rate go up? In the heart.
AV?
Ooh, close. What does it stimulate first? What's your
SA?
SA node, right? You were very close, SA node. So let's do that. What's it conduct? So it starts with SA node, usually adrenaline type drugs, synthetic nervous system, they'll get that. So your chronotrope, your positive chronotropes are adrenergic in nature. They're adrenergic analogs, would y'all agree? So you have to, here's your kidneys, the adrenaline, and you got your catecholamines. What's your catecholamines that live inside your adrenal glands? They're all adrenaline in chemical structure, dopamine, epinephrine, and norepinephrine. Those are your 3 major catecholamines that play a part with fight or flight and the sympathetic nervous system. Would y'all agree? So when we give a positive chronotrope, what is the desired effect? So those are mostly our vasopressors, right? Because they press the vessel and they increase the heart rate. Who would you want to increase the heart rate on? Symptomatic bradycardia. They're thumping along at 30. Do you think there's any perfusion going on with symptomatic bradycardia? Nope. Can they go into cardiogenic shock? Yep, for sure. So we want to give a positive chronotropic heart rate. Conduction, same thing. That facilitates the rest of the conduction. So you've got the SA node. What's next?
B.
AV node. Is there something? Yeah, so the AV node is next, and then what's under the AV node?
Bundle.
His, and then the Purkinje fibers, yes. So the conductivity is pretty much rest of it, but remember chronotropes are mostly heart rate, and the SA node are stimulated. Now, what receptors? Oh, here's some word on test one. What are the receptors in the heart? They're adrenergic receptors. You have A1, A2, B1, B2, right? So what receptors live on that SA node? There's only one heart. So B1s, and what stimulates bronchodilation in the lungs? B2, because you have two lungs, right? That's the best way to do it. So we need, oftentimes, if somebody's crashing, we need to give them a positive chronotrope, which are going to be your vasopressors, like your dopamine, your epinephrine, your norepinephrine, like your levophed, to get the heart rate going, so they don't have an anoxic brain injury or multi-organ dysfunction syndrome. So, as I put in my email, it's all about being easy, the easy button, you guys. There's only one drug, actually, on this list that we're gonna talk about today. I just talked about more positive chronos, but guess what? There's only one positive. Good job, Jen.
I was wondering, cardiac glycogen.
It's a cardiac glycoside. Good job.
It's the only one of all of the cardiac drugs that have a positive ionotrope, right? Everything else is negative, negative.
She's got it. That's it. And if you, that's beautiful. If you can put this into a bucket, there's only one. Is that, are you gonna be tested on those? Yeah, like metoprolol is on here, calcium channel blockers are on here. Maybe ACEs, I don't know what else is on here. Yep, there's some ACEs on here, calcium channel blockers, beta blockers, yeah, all those, are on here. And of course, there's digoxin. That's the only one that has a positive, anything, and it's a contractility. But it's a negative chrono. It's beautiful for heart failure because it will slow down the heart rate, decrease the workload of the heart, and the oxygen demand. That's beautiful. Plus, digoxin makes the increased cardiac output, the contractility. Believe me, we'll do this again. Okay, so that's a good review. Bless you. Oh, they're so bad. And then, so yeah, we're gonna go through those again next week. We're gonna know them. So study them up this week. And then that's it. We have 2 weeks of, don't you like it? There's only 2 weeks of study of stuff. That's not a lot of stuff to study. Okay, now let's get into some questions here. Let me pull up okay, all right, I think I'll go into that. Let's go into some food and electrolytes here. Yeah, let's just do it. Gotta get it the first day, because this is really, really crucial that you know this stuff here. I was looking for a eraser, and we have one someplace. I'm gonna have to steal one from another room. Okay, so I'm gonna leave that there. So we've already gone into a little bit of content for follow along with this. Okay, so we have 3 different types of solutions. Oh, I know what I forgot to put on there. I'll just have you do it. Shoot, I did this last night. To add to that document, there's 2 different types of IV fluids. There's crystalloids and colloids. Oh, darn. I knew I forgot something. I'm gonna add that to it for next time, but please write solutions that you're gonna be doing as a nurse on a sheet there. And that's a crystalloid and a colloid. Okay, now I'm gonna start putting y'all on the spot, okay? You're gonna hate me for this. I'm gonna get to know your names gradually. What is your first name? Gabby. Hi, Gabby. Oh, we have a lot of Gabbies in school. Gabby, do you know the difference of a crystalloid and colloid?
No.
That's okay. Does anybody? That's all right. That's okay.
Colloids are large molecules and crystalloids are small.
Is she right? She's right. So we have, it's all about the size of the solute, the molecules. So crystalloids are going to be things that you can dissolve. You know what? I always bring it, it's like crystalline. Is it a powder oftentimes? Yeah. It's still, yeah, it's probably, is it mixed now? oftentimes they would have powder and then you mix it in water, like Tang. Oh God, that goes way back. Oh yeah, when you say Tang, it's like, oh my God, you are really old. But, yeah, so it's like it's like salt, like when you gargle, it's a crystalloid, right? So it easily dissociates in water, very small molecules. Now, the implications to that is big because those molecules, the crystalloid solutions are designed to go past the semi-permeable vessel. Would y'all agree that your vessels are semi-permeable? God, I hope so. Jeez, because that's how you get salt in there and how your body sort of equalescences out, through the spaces. And we'll get into that. So yeah, so crystalloids are small molecules. Can y'all give me some examples of crystalloid solutions? Yeah, yeah. Your hypo, your iso, and your hypertonic. Now, you can also have hypertonic colloidal solutions, right? But we'll get into that. But yeah, usually it refers to the crystalloids. So would y'all agree 0.9% scorable saline? Yeah, what is that? Is that a hypo, iso, or hyper? Iso, yes. What does that mean? It's equal. It does not provoke moving from cells or out of cells. It is what we have in your body right now. In your serum, your concentration of sodium, well, not after you eat something really super salty, but that goes up slightly and then it equalizes out through the interstitial space in cells. So yeah, 0.9, what else? What other solutions? And I think there's a document that I put back there. Here, I think this is good, right? What other crystalloids do you have? Oh, good job. And what is LR? Is it a hypo, iso, or hyper? Iso, good, yes. What other crystalloids do you have? Yeah, and that's just by itself, 5% is, but when you start adding to that, it becomes hyper. But yeah, like 5%. How about a half normal saline? Like a 0.45, they call it half. It's almost half. Yeah, 0.2. So those are all crystalloids. It's like you can dissolve sugar or salt, or even some of your electrolytes in solution. That's a crystalloid. Okay, what is a colloid? And she said, see, the molecules are bigger, large molecules. In your body, what are large molecules? One word. Keep it simple. Sugar is dissolvable. Proteins. Good job. Proteins, you guys. So think about your big proteinaceous fluids. Proteins like your plasma, your FFP, fresh frozen plasma, your albumin. Even head starch is a sort of made in the lab colloid. We have another name for this. It's going to be called volume expanders, because that's exactly what it does. All right, the difference in these two solutions is this. So a 0.9, like a crystalloid, can pass both ways, right? Would y'all agree? Depending on the concentration. We're going to get with that in a second. But a colloid, you know what they do? Brilliantly, and how they save lives. When you, I swear I'm going to pull that. A colloid, once you give a colloid, like plasma or albumin for your alcohol people, the hypoalbuminemia, see, alcohol people, end-stage liver people, guess how they die? 98% of the time. Guess how? Hemodynamics. It's a hypovolemic shock. If you don't have enough protein in your serum, because the liver, bad livers cannot make serum protein. That's where you get your protein from. Did you know that? Your liver is incredible. Your liver makes serum proteins, like plasma, albumin, all that stuff. If you have a bad liver, it's not going to end up in the serum. So if you have no serum protein, where's that fluid going to go? And what's that called when the fluid's out here? Ascites. Y'all have seen that, right? That's how they die. They die from hypovolemic shock. That's how your liver patients die. Have you ever done CPR in a liver patient? It's so bad. They'll start squirting all kinds of blood and everything out their mouth. You do not want to resuscitate a person. So we resuscitate them with albumin. We give them the protein to pull the fluid in. We're gonna talk about that in a second. I'm gonna start giving you some test answers, okay? So you need to know what colloids do. So this is you, you're at the bedside. You've given, like an alcohol person or a cirrhosis person, some albumin. So what those proteins do is they stay intravascular because they are large molecules. They will not pass back into the interstitial space because they're large molecularly. They will not pass through. Is that a good thing? Yes, it is. Because these proteins that you have here will suck fluid in. They become hypertonic. And I'm gonna have like 2 or 3 questions on your test on that alone. So there's gonna be a question that's gonna ask you. You have an alcohol liver patient that's gonna say, when you're giving albumin, why are you giving it? Well, you're increasing what we call oncotic pressure. What is oncotic pressure? Oncotic pressure is only one thing. Only refers to one solution, colloids, only, so remember that. It's gonna be on your test. I'm already giving you test answers. How could that be? It's true. So the colloids exert, and what's the word? Oncotic pressure. Good job. And again, what that refers to is the pressure created by giving them that protein. So this is it. Salt sucks, sugar sucks, protein sucks. Would y'all agree? And when you have a hypertonic solution, like your crystalloids, like a 3%, or when you give them a protein, where's that fluid gonna move to? Be sucked to the vessel, right? And that's what you want. Because in this person who has, now if you're hypovolemic, what metric are you measuring? What as a part of your triad assessment that you're measuring to tell you that they're hypovolemic?
Labs.
Blood pressure.
Vitals.
Does that make sense? Person in shock, any kind, their blood pressure is low, and this is another mechanism of shock, right? Hypovolemic shock. But when you, the awesome nurse, when you start cranking that albumin in that, guess what happens? You have one of the monitor, right? And when we run albumin, it is fast. It cranks. And it is pulling, so it's pulling fluid from the body into the vessel. But you know what those proteins will do? Again, they will stay and that's why we call it line expander. They stay intravascular. That's how you save the patient's life when you give a protein. Isn't that amazing? So cool. So yeah, so it stays there and it saves her life by expanding the vascular volume and increasing the blood pressure. Because this is all about blood pressure, right? So that's how these alcohol people die. They die of hypovolemic shock, literally. Okay, very good. I forgot to put the colloid crystalloid. I did this really quickly last night when I was exhausted, so I'm so sorry. So let's get into this. Let's get into spaces. Yeah, so there's gonna be a test to differentiate these. Test question, definitely no oncotic pressure related colloids. Oh yeah, how many spaces do you have? You have the intravascular space, interstitial, and intracellular, right? Now, let's get into hypo, iso, and hypertonic, and I'm going to further give you some test answers. Okay, we have a vessel, a cell, a vessel, a cell, and a vessel, and a cell. It almost looks like ho, 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 doesn't it? Okay. I don't know. Every time I write that, it looks like ho, ho, ho. I just need to put this there, but I'm not going to. Okay, hypotonic. What's a hypotonic? What does hypo mean? Low concentration, yes. And as you see, concentration is one of your terms on here, right? Some concepts, now let's apply it. This is like going back to basic patho, right? Just the terms. No, we're gonna think critically and we're gonna apply all this stuff. So there's only, so it's a very low concentration, would y'all agree? That's, so the solutions, the crystalloids are based on concentration, making it either hypotonic. The tonic part is about tonicity. The more solutes you add, the more tone you have. Just think of it that way. So hypotonic, low concentration. And of course, on that IV list, you're gonna have, you know, stuff like 0.2, half, you know, 0.3, not 3%. That's the dangerous stuff. So 0.3, half, which is 0.45, which is very common for maintenance. Oh, we give half a lot. Now, question for your test. Which way, when you give a hypotonic solution, would y'all agree that you're diluting the vasculature environment? Absolutely. You're actually diluting it because it's less concentration than this right here. This right here, right? So like a 0.9, a half is you're diluting the blood. That's good. I'm gonna tell you why. It's gonna all come together, I promise. This is a lot and it's fast, but you'll get it, you'll get it. Where is the fluid gonna move? In the cell. Good job, you guys. Because the interstitial space and the cell has more solute concentration. That makes sense? The problem here is if you leave it going too long, what can happen to those cells? They get lice. You don't want that. You have to watch their neurologic status. That way too, if you're lysing too many, we've got too much of that movement from that hypotonic solution. Now, going backwards a little bit, why are you giving a hypotonic solution? Yes, cellular dehydration. Cellular, how do you know assessment findings that they have cellular dehydration? No, that would be hot. That would be too much fluid in the vessel. Oh, outwardly, signs. Yeah, now they're, yeah. Dry mucous membrane, how about? Yeah, for skin sugar. And how about capillary film? Yeah, see, and oh, what about the big organs? What big organs are you gonna tell you? Give you some gifts that tell you that they're dehydrated.
Kidneys.
Kidneys, and how are you gonna measure the kidney function? BUN, creatinine, and GFR. And what does GFR stand for?
Grammatics.
That's it. Patient, if you work at ED, you see this all the time. People come dehydrated all the time. And I have one question. What's your kidney function look like? And so you have levels of dehydration, then it goes up to hypovolemia, then hypovolemic shock. See how it works? So there's levels. We need to treat it. We need to get them there. Now somebody said, let's see, somebody said something a minute ago, darn. We give this for cellular dehydration. I know what it was. We do not give this for trauma. What do you give for somebody who's actually going into hypovolemic shock? Isotonic. Let's move to hypotonic, or isotonic, excuse me. Why are you going to be giving an isotonic solution bolus, meaning a large volume at a lot very quickly for trauma or hypovolemic shock? Why? To increase the blood pressure without doing what?
Oh, increasing the vessel.
Moving fluid either out of the cell or into the cell. See what I'm saying? It's equalescent. All you're doing, your clinical desired goal, is to bring up the blood pressure just by giving it volume. That's it. So another test question is going to be this. It does not cause any provocation of the fluid moving into the vessel or into the cell. This one, since the concentration is bigger, it's going to suck the fluid this way. This does nothing but fill a cell volume, right? But, you know what happens with the crystalloid? Is eventually, so initially we get them to perfuse organs, right? Get that blood volume up so they don't die, and then it'll equal us out into the interstitial. See where the body will do that over hours, right?
So,
Yes.
for the hypertonic, it's a low concentration, and the isotonic is just an equal?
Regular, yeah, it's equal to what you have in your bloodstream already. So it doesn't provoke, the concentration is equal to what you have physiologically as a human, right? You run every day at a 0.9% saline every day. So it's not provoking movement because the concentration is exactly the same. Isn't that cool? I'm gonna have so many test questions on 0.9. Like on shock, what's the first intervention for a distributive shock? 0.9% saline, so they don't die. So they don't go into MOA, oh, you're gonna get all this stuff. This is easy stuff. You're gonna get all this right. Okay, so we give the ISO for our big boluses to save their lives initially, even if it's a hemorrhage. Now, that's initial. The paramedics will pop in probably a 16 gauge or 2 large bores. Usually in the field they'll do the big 16 gauges. 18, you know, a little less than that. You can still bolus them. You can bolus with a 20 gauge, but a 22, hard pressed to do that because it's so small. So yeah, so this is good. This is life-saving right here. Can we go to hypertonic? You guys ready for some more test questions? Okay. I think that I do have a shot question on what to bolus with. It's going to be this. Now, do they use LR? LR is also ISO. Yeah, sometimes they'll do that. But the most popular one is 0.9% saline, which is isotonic, for the reasons stated. Okay, are we ready? When I talk about hypertonic solutions, it kind of scares me. First of all, you will not be getting a hypertonic solution in any place other than critical care unit, cut and dry. And I'll tell you why. Hypertonicity, would y'all agree? So this is you at the bedside giving a hypertonic solution. These are two. These are on your test, both of them. You're at the bedside giving a very high concentrated solution. What is now going to happen to the movement of fluid in the body, spaces?
Does it shrink?
Shrink what?
Vessels?
Cells. Correct, very good. So now you're pulling from the cells in the interstitial space, because now where are we highly concentrated? In the vessel, right? So now your movement of fluid is going to go inside the vessel. This is good clinically for a couple different reasons that we're going to be tested on here coming up. So, but really the concept here is fluid movement, right? Does it say it on here? I think I have, yeah, movement of fluid. So know these three. So I might have a question that says, you're giving a hypotonic solution. Where is the fluid going to move from? Where is it going to move to? Is that simple enough? I mean, that goes way back to simple, like, I don't know, maybe AFP or cathode. But guess what? It's relevant that I go over this because y'all don't know this. I know you don't know this because I know. Because I ask you questions and then I start talking about, it's like, oh my God, but this is easy, right? This is easy, easy stuff. Even if by memorization, you know what a hypotonic solution does, but you really need to know why. It's all based on, again, concentration of solution. The higher the concentration, the more attractiveness it has to itself, molecularly, if you want to think of it that way. Okay, so this is dangerous. They have to be in critical care. This is why. Now, why? I'm going to ask y'all, and this is going to get into the electrolyte stuff too. This is a perfect crossover for your test. So, why? Does anybody know why you're giving an input solution? I think that we would stick to probably an isotonic to bring up the pressure. But 3% is telling you something is really wrong here.
What do you lower electrolyte?
Which one?
Sodium?
Yeah, severe hyponatremia. You both got it at the same time. This is a saline. This is salt. Saline is salt. As my Russian students would say, saline. I love the way, yeah. I have this group of international nurses at Press, and Natalia would always say saline. So that sounds so sophisticated. Yeah. Yeah, so saline. So 3% saline. So let's think about electrolytes. Let's cross over into some electrolyte talk. You got saline, you got calcium, you got potassium, you got mag, and you got, what am I gonna say? Oh, phos. These are the two big caveats, those are the big fluid movers and effectors. These are really big, these three right here. So when you see that N in the NA on that periodic chart, what does that N stand for? What system? Neuro. Correct. Very, very good. Neuro primarily. I'm taking a deep breath because I'll tell you why. When you look these up, and I think that I have, oh gosh, should I print those up for you? You know what you guys are going to have to study for your CMS? All of the effects of them. Does that make sense? I cannot rob you of saying it's only neuro. It is prominently neuro for sodium. Does that make sense to everybody? But yes, are there more? You know that there's more because you've looked it up. Yeah, there's a lot more. I cannot cover all those. You guys I'm giving you what you need to look up for your CMS. But on your test, on this first test, I'm going to be very specific because this is life-threatening. So yeah, severe hyponatremia. That's why you have to know your triad of assessment and to not kill your patient. You've got to be able to know your labs. Right off the bat, there's one of the first things I look at. I look at my quantifiable stuff, I look at vitals, and I look at my lab. Numbers don't lie, do they? Even though you can have an erroneous lab, I still look at them because it's part of the puzzle, right? So this person here they're having seizures. So how is that going to work? You give a 3% sodium. What is your desired clinical outcome? No seizures. Isn't that easy? That's part of your assessment. You think about problem, intervention, evaluation, or outcome. I'm giving this 3% sodium so they don't have an anoxic brain injury secondary to a seizure, right? That makes sense. Okay, let's go on to the next drug, which will be on your test, by the way, mannitol. Does anybody in this class know why we're doing mannitol? It is an osmotic diuretic. Oh yeah, it's not a protein. These are crystalloids. It's a highly concentrated crystalloid. And it causes osmotic diuresis. How is that? How does that work? Are you pulling fluid into the vessel? The vasculature? Yeah. What's it eventually going to hit? The heart and the kidneys. And then what are the kidneys going to do with all that extra fluid that's been sucked into the vessels?
Excrete.
They're going to pee it out. So they use it for osmotic diuresis. But it's the action, it's the problem that we're really looking at here. Can you give it for glaucoma? Just suck fluid in and then you pee it out. Yeah, because what's the pathology with glaucoma? Increased intraocular pressure. Would y'all agree? So you want to alleviate that pressure. Oh God, did I go past break? Oh no, okay. Yeah, because I do that all the time. So you pull fluid out of the eyes and then they pee it out, but it's a very small dose. But why are you giving mannitol IV in critical care units? That's it, to decrease ICP. They have a traumatic brain injury, You know, somebody bumped their head, they were in a car accident or whatever it is. Now you have swelling in the brain, cerebral edema. How best, this is so brilliant that they do, that we can do this. You can actually suck fluid out of that brain tissue and decrease ICP, intracranial pressure. Absolutely correct. Do you see how that works with the, just playing around with the concentration of solutions? You could save the lives of patients just by knowing these three solutions and how they work. But let's get into this. This is also going to be on your test. You're going to need to know what manitols you start. Certainly later on down the line when we talk about neuro, TBIs and stuff like that. But also for this test, they're going to have this for seizures. Yeah, seizure-free is what we're trying to do here. But are there some dangerous, sort of expected side effects to come of giving a hypertonic solution? So in other words, you have to monitor for what? Yeah, neurostatus, to make sure it's working, right? To make sure it is working. Like seizure-free. What else? What else can happen when you give hypertonic solution? Done. End of story. Oh, and there's another one too. So can they get hypervolemic really quickly? Yeah, because really, systemically, not only are you pulling fluid from the brain, you're pulling it from the body. And you can't just stop it, like right here, you know? It's systemic, it's IV. So it's pulling fluid. But you're getting that vascular volume initially is going to be really plump, isn't it? So that can result in hypervolemia. Where does it sit here? Where was I? Is this my hypertonic right here? Oh, this one here. I need to take that, it's confusing me. Okay, so yeah, so are they initially going to be hypovolemic? Yeah. Is that a problem? Hypervolemia. What does emia mean? Blood. So the bloodstream now is engorged with fluid because it's pulling in, that hypertonic solution is pulling in the fluid. What does that hypervolemia lead to that could be life-threatening? What do you think? Pulmonary edema. Done. You could kill your patient so quickly. Oh, and the other thing too, yeah. So it's pulmonary edema, because coming from the heart's going to have all that fluid, and it's going to go right, right ventricle is going. All that extra fluid, vascular fluid, is going right to the lung. How can you tell? How can you assess if they have pulmonary edema? Crackles is number one. What else? Very good. Huh? Wait, what? Shortness of breath. If I don't hear, it's because my ears get filled with fluid. I'm so sorry. I need to say JVD. Yeah, exactly. JVD, right? Some JVD. But mostly lungs right now for pulmonary edema. That would be, right side of heart failure there. But yeah, so crackles, the shortness of breath is big because the alveoli, the little sacs, are getting filled with fluid very, very, very quickly. That's where gas exchange happens, right? So the hypothalamus dual oblongatus, so I can breathe faster, and they really can't get that big gas exchange. How about their pallor? Yeah, lack of oxygenation, since the alveoli are filling up with fluid. You could literally kill them with this mannitol. So in other words, this is one of the times you do not go downstairs to get a donut. This is not the time. When you hang a mannitol drip, you are going to be equipped with maybe some cheese sticks and some water or something. It is not time to take a break. And the reason I say that realistically, if you give a report, oh, I just hang on the mannitol drip, and you're leaving your patient, no, you're not. You're staying on the unit and you're surveilling them so you don't kill them. Because that other nurse, do they have 3 or 4 patients to take care of over there? Of course they do. They have other patients. They don't care about your patient. They may, but you see what I'm saying? Their priority is their load, their patient load. oh yeah, that's right, I'm covering for so-and-so. See, they do that, that's an afterthought for them. Their priorities do they have under their belt already? Yours is just an extra. No, you're not leaving the unit. There's another reason that when you give a hypertonic, whether it's 3% or mannitol, that you could kill them. What's another mechanism? Did you say hypertension? Well, they definitely gonna be hypotensive, aren't they? They're gonna be hypertensive, aren't they? They're gonna have, why are they gonna have hypertension? Because they're hypervolemic. Hypertension, oh, this is so easy, you guys. Hypertension equals two things: vasoconstriction, or lack thereof, and volume. Done. That's what hypertension is either too much volume or too much constriction. That's how easy. So they're actually going to be hypertensive, not hypotensive. Because are you sucking fluid into the vessels, causing the blood pressure to go up? But that's actually not the answer. What's the answer? How are you going to kill a patient? The other way you're going to kill a patient. Are we dehydrating a particular organ?
Mm.
No, the kidneys are going to be